Welcome to This Week in Anesthesiology. This week we're covering 10 notable papers spanning perioperative blood pressure and hemodynamic management, organ protection and recovery from anesthesia, regional analgesia and chronic pain, and a pair of studies that ask harder questions about the quality and the equity of our evidence base. Let's dive in. We start with hypotension, because two of the week's papers land squarely on the same nerve, and both are negative. In anesthesiology, Eichinger and colleagues randomized just over 500 patients aged 45 and older, with cardiovascular risk factors undergoing major non-cardiac surgery at two Austrian centers, to either a crystalloid bolus given within about an hour before induction or standard care. The primary outcome was the time-weighted average of mean arterial pressure below 65 millimeters of mercury in the first 20 minutes after induction. The median in both arms was 0, and the difference was not statistically significant. The plain language message is that preloading with fluid before induction did not prevent post-induction hypotension in exactly the population we most worry about. That's a useful piece of de-implementation evidence for anyone who reflexively hangs a liter of crystalloid in the holding area. Alongside that, the British Journal of Anesthesia published a systematic review and meta-analysis by Sakova and colleagues of randomized trials that assign patients to higher versus lower intraoperative mean arterial pressure targets. Across 9 trials and nearly 15,000 patients, there was no difference in 30-day all-cause mortality, and across 13 trials, no difference in acute kidney injury or myocardial injury either. Importantly, the authors are candid about why. The separation in blood pressure actually achieved between the higher and lower target arms was small, and stratifying by the size of that separation didn't change anything. So this is not proof that hypotension is harmless. The observational association remains strong. It's evidence that the trials we have so far haven't tested the question with enough contrast. Read together, these two papers should make you more skeptical of low-yield preventive rituals, and more attentive to the fact that causality in intraoperative hypotension is still genuinely unsettled. When you do need to prevent hypotension, the obstetric literature keeps refining the vasopressor answer. In Anesthesia and Analgesia, Basso and colleagues ran a randomized, double-blind up-and-down study to find the dose effective in 90% of patients for an initial prophylactic norepinephrine bolus, followed by an infusion of 0.05 micrograms per kilogram per minute in elective cesarean delivery under spinal anesthesia. 60 patients later, the ED90 came out at 0.157 micrograms per kilogram, call it 0.16, with effectiveness rising monotonically from about 60% at 0.13 micrograms per kilogram to 100% at 0.19. Adverse events were modest: transient hypertension in about 8%, nausea in 10%, and one case of asymptomatic severe neonatal hypoglycemia. For a 70 kilogram parturient, that's roughly an 11 microgram bolus at induction of the block, then a fixed infusion titrated to response. It's a small single-question study, but it fills a real gap for units that have moved from phenylephrine to norepinephrine and have been guessing at the loading dose. Our second theme is organ protection and safe emergence. Also in anesthesia and analgesia, Wyke and colleagues randomized 89 adults undergoing elective cardiac surgery to a cardiopulmonary bypass flow of 2.9 versus the standard 2.4 liters per minute per square meter, with mean arterial pressure held between 60 and 80 in both arms. Increasing flow by 20% cut urinary renal injury biomarkers by more than half at 60 minutes after bypass. Both N-acetyl beta-D glucosaminidase and the TIMP 2x IGF-BP7 product and serum creatinine stayed below baseline for the first 3 postoperative days in the high-flow group, while rising above baseline in the standard flow group. Norepinephrine requirements were significantly lower with high flow. Clinical acute kidney injury was numerically less frequent, 16% versus 25%, but the trial was nowhere near powered for that, and the difference was not statistically significant. So this is a biomarker-level signal with a plausible mechanism, not a practice mandate, and the authors rightly call for multi-center confirmation. Notice, though, how it dovetails with the hypotension meta-analysis. Perfusion may matter more as flow and oxygen delivery than as a number on the arterial line. On the recovery side, Fleming and colleagues report a before and after study, again in anesthesia and analgesia, in 135 obese adults undergoing elective intra-abdominal surgery. Implementing a structured protocol of quantitative train-of-4 monitoring plus weight-based sugammadex dosing reduced the postoperative hypoxemic burden. The area under the curve for oxygen saturation at or below 90% over 24 hours, captured by a wearable continuous oximeter from a median of 123 to 74 saturation percent minutes. Sugammadex dosing effectively doubled to 4 milligrams per kilogram, and rocuronium use rose slightly, presumably because clinicians dosed with more confidence when they could measure. Length of stay and recovery and supplemental oxygen use were unchanged. 2 lessons here. Quantitative monitoring plus adequate reversal measurably improves postoperative oxygenation in high-risk patients, and continuous oximetry detected far more hypoxemia than ever made it into the medical record. A reminder that our ward monitoring is largely blind. And on the front end of the perioperative pathway, the British Journal of Anesthesia published a meta-analysis by Liu and colleagues, comparing supervised and unsupervised aerobic prehabilitation across 42 studies and roughly 5,000 patients. Supervised exercise improved peak oxygen consumption and 6-minute walk distance and reduced postoperative complications by about 40%, with a larger reduction for high-intensity programs. Unsupervised exercise improved only walk distance and did not reduce complications. Crucially, no study compared the two head-to-head, so this is indirect evidence. But if you are building a prehabilitation service, the supervision appears to be part of the active ingredient. Turning to regional anesthesia and pain, the Journal of Clinical Anesthesia reports a randomized trial by Newmy and colleagues in 92 adults having unilateral total hip arthroplasty under spinal anesthesia, comparing an ultrasound-guided pericapsular nerve group block with an anterior quadratus lumborum block, each with 30 milliliters of 0.25% ropivacaine plus dexamethasone. There was no difference in 24-hour fentanyl consumption, no difference in time to first rescue analgesia, and no difference in pain scores, hemodynamics, or nausea and vomiting. Practically, that means the choice can rest on your own technical comfort, the motor-sparing profile you want, and patient positioning. In regional anesthesia and pain medicine, Keith, Kilgore, and Provenzano retrospectively followed 124 patients through spinal cord stimulation trialing and implantation. Pain fell substantially after the trial, and benefit was sustained, if attenuating, out to 36 months. But the trial phase metrics explained relatively little of the variance in later outcomes, with the change in numeric rating scale performing best and still peaking at an R-squared of only about 0.32. High and moderate trial responders did not differ meaningfully later on, and patient-reported versus calculated percent pain relief agreed poorly, with limits of agreement spanning roughly minus 36 to plus 56 percentage points. If you use percentage pain relief as your gatekeeping criterion for implantation, that number is less reproducible than it looks. Finally, 2 papers ask us to look at the evidence itself. In Anesthesiology, Odalora Esteban and colleagues calculated the fragility index for 161 superiority randomized trials, cited in North American and European perioperative guidelines. Median sample size was 120 patients, and the median fragility index was 4, meaning that for a typical guideline-supporting trial, changing the outcome status of 4 patients would flip the result to non-significance. Pediatric trials were the most fragile, single-center trials more fragile than multi-center ones. That is a sobering frame for much of what we practice by. And in the British Journal of Anesthesia, Aman and colleagues linked Swedish national registries for nearly 59,000 acute hip fracture surgeries. 30-day mortality was 7.9% and 2-year mortality 35.3%. And educational attainment showed a stepwise gradient. The least educated group had about a 25% higher adjusted odds of 2-year death than the most educated. An absolute risk difference of just over 6 percentage points, with an attributable fraction of 14%. In a country with universal health care, socioeconomic status still tracks survival after hip fracture. If you only have time for one paper this week, make it the anesthesiology trial of preoperative crystalloid bolus. It directly tests a widespread, low-evidence habit in high-risk patients and tells you clearly that it doesn't work, which is exactly the kind of finding that changes Monday morning. Here are the key takeaways from this week in anesthesiology. First, a pre-induction fluid bolus does not prevent post-induction hypotension in cardiovascular risk patients, and randomized trials of higher versus lower intraoperative pressure targets still show no mortality, kidney, or myocardial benefit, largely because they have not achieved meaningful blood pressure separation. Second, for elective cesarean underspinal, an initial norepinephrine bolus of about 0.16 micrograms per kilogram, followed by an infusion, is a reasonable, evidence-based starting point. Third, quantitative neuromuscular monitoring with full-dose Sugamidex measurably reduces postoperative hypoxemic burden in obese patients, and continuous oximetry shows how much hypoxemia we currently miss. Fourth, supervised higher-intensity prehabilitation is associated with fewer postoperative complications, whereas unsupervised programs are not. And fifth, be humble about the evidence. Guidelines supporting perioperative trials are small and statistically fragile, and even in Sweden, education and income predict survival after hip fracture surgery. That's your roundup for this week in anesthesiology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you've been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one in any of 31 languages. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.